Hi everyone, it is Teresa Rohde and I just wanted to record Chapter 2 PowerPoint for Pharmacology class. This is about safely preparing and giving drugs. I will let you guys know that on Friday we will cover Chapter 3. We will start some of the dosage calculations. Remember this quiz that opens up tonight at 1800 this evening, quiz 1, is not related to any type of dosage calculation questions at all. It is strictly based on the material that we covered last week in Chapter 1. So the information for Chapter 3 that we're going to be discussing Friday in class will be your quiz next week. Okay, so with that being said, let's go ahead and get started. By the way, if you guys have any questions, since we can't interact with this recording, please feel free to reach out and email me. I know that a lot of you are concerned about the material this week, so I wanted to make sure I got this PowerPoint completed for you pretty quickly. So we are going to talk about safely preparing and giving drugs today. Okay, as far as objectives go, there are 8 rights of giving drugs or giving medications that we are going to discuss. We are also going to look at 4 types of drug orders. We are going to look at describing ways to prevent drug errors, and we are going to learn about important principles related to preparing and giving drugs. So these are very fundamental concepts of pharmacology and safe med administration. And this is a very robust chapter. There's lots of information in several dozen slides. Okay, so as we talk about overview of medication administration, let's talk about our role as a nurse in drug therapy. So we are responsible as nurses to provide competent and safe patient care. And administering medication safely is one of the nurse's most very important responsibilities. So that's our role as nurses. We give the drugs directly to the patient. You have physicians, dentists, podiatrists, advanced practice nurses, and physician's assistants who select and prescribe drugs. And then you have pharmacists who mix and dispense medications. So what as a nurse do you need to be safe in medication administration? Well, you need to know the purpose of why your patient's receiving the medication, what the medication does or its action. You need to know a couple side effects, any abnormal reactions. You need to know how the medication can be delivered, which route, and any necessary patient teaching and follow-up care. So you also need to be familiar with the Nurse Practice Act for their state, which in this case would be Missouri, and you need to understand your scope of practice regarding medication administration in the state of Missouri. You must understand the basic principles of drug administration, including checking the expiration date of a medication, looking for any discoloration or sediment in IV medications, washing your hands, following the 6 rights of drug administration. You have to be able to understand your role in monitoring the patient for expected results and side effects, patient and family teaching, and when it's important to notify the provider in regards to medication safety in patients. So you have quite a large responsibility as a nurse when it comes to medication administration. So we talk about 6 rights of medication safety administration. The first right is the right patient. So we always want to make sure that we're giving the medication to the right patient. Then the right drug. So we always want to make sure that we're giving the exact right medication to the right patient. The right dose. This is very important. We don't want to overdose or underdose the patient, right? So we need to make sure that we're giving the right dose of a medication. Also, we want to give it the right route. Not all medications are given oral, although we did discuss a little bit on Friday about how oral medications are the most commonly administered route of medication. We want to make sure that we give it at the right time when it's ordered, and typically in facilities you have an hour prior to the due date and an hour after the due date of the medication to give it. And then the right documentation. So guess what? If you don't chart that you administered a medication, what could happen? Right, somebody could easily come along after you, it looks like it was not given, so they may administer the medication. So then we just double dose the medication. That is a medication error that would have to be reported. Okay, as far as checking the right patient, we're going to look at each of these rights in a little bit more depth. So, the Joint Commission recommends checking at least 2 unique patient identifiers before medication administration. What are these 2 unique patient identifiers? Well, they are name and birth date. So it's very easy to ask an alert and oriented patient their name and birth date and get a very realistic answer. You need to compare their name, birth date, and identification number of their wristband. So all patients should have some kind of wristband identifier with the medication administration record, otherwise known as the MAR. Now, sometimes your patients are confused, so you're not going to be able to really rely on their answer to what is their name and birthday. They may have a family member in the room. You may want to use the family member as a resource. Sometimes, if you're working in long-term care, for example, in an Alzheimer or dementia unit, they may use pictures of patients in long-term care to help you to identify the patient. The problem with this is the picture needs to be up to date. So you need to make sure the facility is using up-to-date pictures. How many times do you see pictures of residents that are not up to date and the resident looks nothing like they did in the picture? So we need to make sure to be the most safe that these pictures of patients in long-term care are current and up to date and actually look like the patient in real life. Okay, the right drug. So always be sure you have the correct drug. Compare the drug to be administered with the drug order. Thousands of drugs have similar names. I'm thinking of Isordyl and Isoprel. So Isordyl is Isordil and Isoprel is Isuprel. They're very similar but very different medications. That's just an example. So what could happen if you administer the wrong medication? So besides making a drug error because you're not following the right drug right of medication administration, you could also cause a patient's death. So obviously you are no stranger to the name Redonda Voigt and her particular lawsuit related to giving vecuronium instead of Versed as ordered for her patient that was going to MRI or CAT scan. So this is huge. If you give the right medication, then you're going to be the most safe. Okay, so errors and deaths for patients can happen. This is real life. It seems so simple and so easy to make sure it's the right drug, but in her case, she overrode the medication. She clearly did not make sure that it was the right drug. She just assumed that it was by looking at the vial, and so she gave the medication. It's just an example, everyone. Okay, and then right dose, route, and time. So this information that is the minimum information for a written prescription is required by the U.S. government. So in order for a physician or provider to write a written prescription, all of the following things have to be included. So you need a date, you need a patient's name, you need the name and address of the prescriber, you need the generic or the brand name of the drug. So you don't have to have both, but you have to have one or the other. You need to have a strength. You need to know the number of times per day the drug will be taken, so the frequency. You need to know any specific instructions for use, so anything you want the patient to know, any directions that they want the patient to follow while taking the medication need to be very specific and clearly written in or on the prescription. Also, the physician or provider is going to have to write the number of doses to be dispensed. So is it a 30-day refill? Is it 10 pills? Is it 2 days? Whatever that may be. Then the number of refills allowed, and must have the prescriber's signature on the prescription in order for it to be considered valid. And okay, so if you are taking an order for a medication, so it's not going to be a written prescription. If you're taking an order, what should you do if a drug order seems unclear? What if the drug dosage is higher or lower than you expect? You're going to contact the prescriber, correct? Now, as you gain more experience in nursing and in medication administration, you're going to become pretty familiar with the names and dosages of very commonly administered medication. So you're going to be able to pick up and catch on to like a wrong dosage amount or a wrong medication as time goes on. So some of that will come with experience. So as far as accepting verbal orders should be accepted only in an emergency. Verbal orders must be written by the nurse and signed off by the prescriber after the emergency. When you take a verbal order, it is very important that you repeat the verbal order. So we call that a verbal order with readback. Just to clarify that is the actual medication order that the prescriber wants. Once you enter that order into the computer, or you write it on a piece of paper if you're still using paper charting, that order must be signed by the prescriber in order for it to be a valid order. Okay, and then we talk a little bit about right documentation. So record drug administration immediately. Like I mentioned in an earlier slide, if I forget to record a medication, someone may come behind me and go ahead and administer that medication because technically it looks like it wasn't given. It's especially important for PRN medications to make sure that you document the drug administration immediately. So PRN drugs are given on an as-needed basis. Okay, what would happen if the nurse failed to document a pain medication properly? What would happen? Well, the patient could then report pain to another nurse and receive a second dose of pain medication. If we're talking about a narcotic pain medication, for example, that can be very life-threatening if the patient receives the incorrect dose, like too much of a dose of that narcotic medication. Okay, right diagnosis. So, the patient's diagnosis should match the drug's purpose. What should the nurse do if the diagnosis does not match the drug's purpose? You should certainly question the prescriptions. So you need to be familiar with your patient's medical diagnosis. You should get this type of information in an SBAR report from shift to shift, but just in case you don't, you may need to just make sure that you look in the patient's chart to ensure that they have that diagnosis. Okay, you need to check any related lab tests. So what kind of lab test would you check? Well, any drug levels that the patient may have had ordered, because we're trying to prevent toxicity, right? Any lab values related to organ function, such as liver and kidney function, and we discussed a little bit of that on Friday. Now, if I was going to give insulin, I'd want to make sure my patient's diabetic, and if my patient's not diabetic, I want to understand why they're receiving insulin. And then also, what laboratory tests do you think I would want to check prior to the administration of insulin? Good, I'd want to check their blood sugar. I don't necessarily want to give my patient insulin if their blood sugar is already on the low side. Very good. Okay, another really important thing to keep in mind is that a patient has a right to refuse any medication. So it's very important that if they refuse, that it is documented. So the first thing we need to do, though, after a patient refuses a medication is we need to try to do some teaching with them to understand why that medication is being prescribed and why it's important that they take it, as well as the consequences of refusal. So let's say your patient doesn't want to take their blood pressure medication. So you as the nurse are going to educate them as to why they need to take it. So maybe you want to tell them what their blood pressure is in that moment, because maybe it's high. It probably is if they're due to take their blood pressure medication. And then what the consequences of that could be. So, Mr. Smith, I'm really concerned that if you don't take this blood pressure medication, since your blood pressure is already a little high right now, that it's just going to get higher and higher. And that could result in you having to be transferred to the ICU for uncontrolled blood pressure. It could mean that your hospitalization will be longer. So try to educate them and really help them to understand the importance of taking the medication. Now, if they still refused, that's fine. We're going to make sure that we document that. We have to do something. We can't do nothing. So, okay, they refused, but why did they refuse? So I always put what the reason that the patient states that they refused. And also you want to include any teaching you did and that maybe they verbalized understanding of the consequences of not receiving the medication. There's no reason to have an argument with a patient about their refusal. We just want to make sure that we educate them, answer any questions, and then document accordingly. Okay, there's 4 different types of drug orders, like I mentioned in our objectives. There's standing orders. These orders are written when a patient receives a drug on a regular basis. So, a PRN order is as needed. So this is given to the patient as needed with a designated time interval between doses. So PRN medications, typical examples would be pain medications, medications for nausea, medications for fever, medications for constipation. These are just some examples of PRN medications that your patient might receive. Then we have single dose orders. So a single dose is in order to give a drug only one time. So an example would be your patient is having a blood transfusion and they're going to receive 2 units of blood. So in between those units of blood, the physician may order furosemide or Lasix 20 milligrams IV times 1 between units of blood. Okay, so I give it once in between those units, and then the order automatically discontinues from the MAR or the medication administration. There's also stat orders. Stat orders are typically given one time and as soon as possible. So if you're wondering what the difference between a single dose order and a stat or immediate order is, the difference is that stat order must be administered immediately. Okay, so what kind of drug errors can occur? Well, there's lots of drug errors that can occur because one or more of the rights was not followed. So there can be errors of omissions. There can be wrong patient errors. There can be wrong dose errors, wrong route errors, wrong rate errors, wrong dosage form errors, wrong time errors, and errors in preparation of the dose. So typically nowadays, there's barcode scanners that are used by nurses and MAs for medication administration. It has made drug errors a little less, and it has made medication administration a little bit safer. However, even though the barcode system has been proven to dramatically decrease the number of drug errors still exist today, despite these sophisticated systems that are supposed to be safer, because nurses do not follow those 6 rights of medication administration. So how do we prevent drug errors? Well, we always follow the 8 rights. When in doubt, check your dosage calculations with the coworkers. I always say 2 heads are better than 1. 2 pairs of eyes are better than 1 pair. Listen to the patient if they question a drug or dosage. Some patients are extremely knowledgeable about their medications and their dosages, and they're very literate in medication safety. And so if they question it, I always double check. You want to concentrate on the task at hand. It's so easy to get distracted, especially in a healthcare environment. Typically, when we talk about medication preparation rooms, they should have a sign that's up somewhere, either on the door or on the wall, that says it is a quiet space to please be quiet while nurses and MAs, etc., MTs are preparing medications for patients. You want to avoid distractions and interruptions. And also, the barcode systems, as I mentioned in the previous slide, do help to decrease errors, although they do not prevent them entirely. Okay, so this is actually an example of a barcode system. So this one obviously looks a little bit out of date, like a little bit large, but you can see there that the nurse or med tech or whoever is scanning that patient's identification band to verify that the correct MAR is going to pull up in the system. Now, we still ask the patient their name and date of birth. Just because you have a barcode system where you work or where you're going to work doesn't mean we still do not identify the patient. Okay? Okay, so as far as reporting drug errors, guess what, guys? We all make mistakes. I've made a ton of drug errors. Fortunately, I have not made any serious or egregious medication errors in my nursing career. With that being said, rushing and fatigue are probably the 2 biggest reasons that healthcare professionals make drug errors. So we want to make sure that we report these errors immediately. Your place of employment should have a system for reporting errors that's fairly easy to follow. Those errors should then be reviewed by a pharmacist and or some kind of quality improvement team and the nurse leadership. And guess what? They look for patterns. If the same error's happening over and over again, then they're probably going to make a change in the process. So you're not telling on yourself to make when you make an error. I don't want you guys to think it's naughty, Teresa's in big trouble because she made a medication error. Really, the goal in reporting drug errors immediately is for safety. A, we don't want it to happen again. And also, we don't want our patient to have any adverse effects. So once you report it and notify the prescriber or physician, you really need to carefully watch that patient for any signs of any adverse reactions. Okay, so the sooner you report, the sooner we can take measures to counteract possible adverse reactions to medications. Again, why is it so important for us to monitor our patient for adverse reactions when a drug error has occurred? Well, it can result in life-threatening complications for the patient, such as coma and death. So, as I mentioned, most patient care facilities have a form and a standard procedure that is used to report drug errors. Okay, so as far as principles of medication administration, well, you need to know the drug's use, actions, common adverse reactions, and special precautions. I will tell you what, like I mentioned, you will become familiar with certain medications that you administer on a daily basis. However, new medications are constantly being developed every single day. Also, some medications you may not give for an extended period of time. So as a nurse who's been around a long time, I still come across medications that I don't know what they are or what they do. So you always want to make sure that you look those medications up prior to giving them so that you know the uses, actions, adverse reactions, and special precautions. You also want to know about your patient's drug allergy. So you want to know about their drug history, drug allergies, previous adverse reactions, pertinent lab values, and any changes in their conditions. The more we know, the better equipped we are to help ensure the safety of the patient while receiving that medication. We can also do a better job of educating the patient on exactly what signs and symptoms to look for if we think they're going to have a reaction. Always listen to your patients. One of your primary jobs as a nurse, besides providing safe care, is to be an advocate for your patient. Always listen to them, always advocate for them. Okay, so important guidelines when you're going to give a medication. So we've already touched base on a couple of these, but you always check the order first. So you're always going to compare the written order or transcribed order first. You want to limit interruptions and distractions, as we talked about. You want to wash your hands. You want to keep drugs in their containers or wrappers until you are at the patient's bedside and avoid touching pills or capsules. So at SSM, for example, they have a program where when you come in as the nurse to administer a medication, they want you to use cavi wipes and wipe down the area where you're going to be preparing the medications and administering them. So use cavi wipes to do so. They're very, very specific in their policy about the use of cavi wipes to ensure that there is a clean, disinfected area where you're preparing medications. So it's important to know your facility's policy as well in regards to hygiene and medication administration. So you never crush tablets or open capsules without first checking a drug guide. You guys, there's a reason tablets are whole. There's a reason that capsules exist. Not all tablets can be crushed. Not all capsules can be opened. So what should you do if your patient cannot take a pill or a capsule but has them ordered? And you know that you cannot crush and you cannot open them. So you want to contact the prescriber. You may even want to contact a pharmacist because there may be a liquid form or another form of the drug that will be a better option for this particular patient to take. That way, instead of the patient not receiving the medication, they are receiving the medication just by a different route. Okay, you never give drugs prepared by someone else, ever. Why not? Why do you think you never give drugs prepared by someone else? Because honestly, it's their word against yours. You really don't know what they've prepared in that syringe, for example. It's a lot of trust that you have to have in that person. So really, you don't know if there's the correct dosage. You don't know if the correct medication is in that syringe, for example. You don't know. So a good rule of thumb is just to never, ever give drugs prepared by someone else. You want to always make sure that you use sterile technique with syringes and needles. You want to be alert to drug names that sound or look alike, as we mentioned earlier. You want to make sure that you document the administration of a medication in a very timely manner. And after giving the drug, you want to document the administration and you want to check the patient for any side effects and/or adverse effects. Okay, now we're going to start talking specifically about routes of administration. So, a couple more objectives we're going to add in now that we've covered the first ones. We are going to describe responsibilities of the nurse related to giving enteral drugs. We are going to describe the responsibilities related to giving parenteral drugs. We are going to describe responsibilities related to giving drugs through the skin and mucous membranes. We're going to describe responsibilities related to giving drugs through the ears and eyes. And we're going to list responsibilities before and after the medication has been given. Okay, so this actually may be a good time for you to take a break. It's been about 30 minutes of lecture, so if you need to take a break before we pick up the rest of these slides, there's 57 slides and we're now on slide 20, so it is a lot of information. So I would encourage you at this time, if you need to pause the recording, take a 5-minute break, and then jump back on. Okay, so enteral drugs are most commonly given by the oral route. These are ordered as PO. That's how you're going to see an oral medication ordered. It's going to say PO, meaning by mouth or oral. These include tablets, capsules, and liquids. Your patient must be able to swallow, and the onset of action is slow. So, what are some advantages to enteral or oral or PO medications? Well, they're relatively inexpensive compared with other drug forms. They're very easy to give as long as the patient can swallow. In the case of accidental overdose, the drug can be removed by pumping the stomach or causing the patient to vomit. When would oral drugs not work well? Well, I would not want to give an oral medication to a patient who is suffering from nausea and or vomiting, because chances are that patient will vomit that medication up. Now, as far as the onset being slow, why do you guys think the onset is slow with oral medications? Well, because they must be absorbed through the GI tract, which is like 30 something feet long. So it does take a while for that medication to make its way through the GI tract. Okay, so when we talk about the specific procedure to give an enteral medication, we want to sit the patient upright with a full glass of water ready. Why should we have a full glass of water for the patient to drink? Well, oral medications dissolve better and cause less GI discomfort when they are given with water. Now, not all of your patients need a full glass of water or are going to want to take a full glass of water to take their medications. But as the nurse, you just encourage them and again, educate them, explain them that they will dissolve quicker and have less GI discomfort if taken that way. It may work, it may not work, but at least you've done your due diligence and performed an intervention as the patient's nurse. So you want to explain the drug and any special instructions. It doesn't matter if the patient's been on the medication for 25 years. You as the nurse still need to tell the patient, okay, Mr. Smith, I have your lisinopril here, and this is for your high blood pressure. Okay, Mr. Smith, I have your oral vancomycin here, and this is for your C. diff, and this is the one you take every 6 hours. So every single time you administer medications to a patient, no matter how long they've taken them, you need to explain what medication you're giving them and any special instructions. You also need to, as we discussed, have the patient swallow the medication and drink the entire glass of water. Could be easier said than done, but we at least need to try. You need to remain at the bedside until the entire drug is swallowed. You want to ensure that the patient receives the full dose of the prescribed medication. You never ever leave drugs at the bedside to be taken later. I cannot tell you as a nurse how many times I've walked into a patient's room and seen medication sitting on the counter in plain sight, not locked up for anyone to take. That's very dangerous. It's a very unsafe situation. So drugs should never be left at the bedside, ever. These drugs may not get taken ever. The patient may save them and overdose on them, or a visitor may take them. Now, you may have a couple exceptions to this rule, like antacids, for example, and or nitroglycerin tablets, if there is an order permitting this. So there must be an order permitting the allowance of these medications to be left at the bedside. Even if medications are left at the bedside, you're going to have to ask the patient whether or not they're taking them and then document that the drugs have been taken. And you must witness this if it occurs. So again, there's a lot of patient education that needs to occur if we're going to leave medications at the bedside. You also need to have a physician or prescriber order to do so. Okay, oral liquid drugs. We want to use a calibrated device to measure the correct dose. Why? Well, typically household devices such as spoons or cups vary in size and their result can vary in inaccurate doses. So typically we use the little tiny 1 ounce or 30 ml medicine cup. When we use that medicine cup to put medication in, liquid medication, we want to make sure that we're eyeing that cup at eye level. So bend down, lean over, and look. And the base of the meniscus should be level with the line on the scale. So here's a couple examples of other calibrated devices besides a medication cup. You see kind of a dropper there in figure A, and then in B you see syringes because obviously they're calibrated as well. So these are also great examples besides a medicine cup of calibrated measuring devices that you may use with medication administration. Okay, so now we're going to talk a little bit about giving enteral drugs through NG or nasogastric or a PEG tube, which is a percutaneous tube that's inserted. So you want to ensure that the tablets that the patient has ordered can be crushed or the capsules can be opened if you're giving drugs through a tube. You want to place the patient upright. This helps to prevent the patient from aspirating. You want to check the tube placement, so follow your facility's protocol to do so, to make sure that the tube is in the correct place. You want to dilute any liquids, crush and dissolve tablets, and empty and dissolve capsules. Now, typically, it's more safe to crush each medication and dissolve each medication one by one and give the patient that medication. Do you know why? Does anyone know why we don't just dilute and crush and dissolve everything together and give it all at once? Now, we used to do this. That was common practice. But nowadays, to help ensure safely, we dilute and crush and dissolve each medication one by one and administer each medication one by one. We usually just flush with maybe 20 cc's of water in between each medication, but then we know which medication the patient received and which one they did not, just in case for some reason they didn't receive them all. We know which ones they did. When you mix them all together, you don't know who got what when. Okay, we typically let the drugs run in by gravity. We flush with at least 50 mils of water to prevent clogging the tube after giving the medications. And then you clamp their feeding, if they have a feeding going, for 30 minutes before you reattach the patient. Why do we do that? Well, if they're attached to suction and we attach it right away, it's going to suction all those medications up into the suction canister, right? So the patient has no time to absorb them. And if you have a feeding going, it could cause GI upset. Okay, now, enteral drugs are also considered rectal drugs. So these are patients who are unable to swallow, who have severe nausea and vomiting. How do enteral or rectal drugs come? Well, in the form of suppository or enemas. So a suppository is a small drug plug designed to melt at body temperature when placed within the rectum or the vagina. The problem is absorption of these kind of medications is not as dependable or predictable as when drugs are given oral. The other thing is a patient with diarrhea, for example, could not hold a suppository long enough for absorption to take place. So this is not always the best route for some patients in their conditions. So you really want to check for health problems that make this route undesirable. Again, diarrhea being an example. That's probably the most undesirable thing. And then you want to make sure that you have your medication, a water-soluble lubrication, and disposable gloves to the bedside when you do administer a rectal medication. You want to assist the patient to a left SIMS or left sideline position if possible, if it's not contraindicated. You want to make sure you protect the patient's privacy. Please explain the procedure. Obviously, this is not a pleasant procedure for anyone involved, so I would make sure that the patient understands what's going to be happening. You're going to put on gloves, unwrap the medication, lubricate the drug and your finger, and you only need to push the medication or suppository into the rectum about an inch. You really, in theory, want to remind that patient to remain on their side for at least 20 minutes if possible. Not all patients are going to be able to do so, but that would be the ideal situation. Okay, now we're going to talk about parenteral medication. So, parenteral drugs are injected through the skin. These can either be intradermal, subcutaneous, intramuscular, or intravenous, and I mentioned these on Friday in theory. There's 4 primary reasons that we use parenteral drugs instead of PO drugs or another type of enteral medication. The patient may be unable to take oral medications. They may need, due to their medical condition, a drug that acts rapidly. They may need a constant blood level of a drug, and they may need a medication or a drug that's not available in oral form. Okay, so in terms of giving parenteral drugs, you want to make sure that you wear gloves. You use needles and syringes very safely. Fortunately, most hospitals and healthcare facilities use needleless systems, retractable needles, or needles with plastic guards that flip over the needle to prevent against needle sticks. Here's a key thing. You need to understand how needles and safety syringes work before you use them. Okay, you don't want to have a user error where you don't know how a piece of equipment works. Sorry, guys. You don't know how a piece of equipment works and you stick yourself trying to get it to work correctly. So being educated on how these safety devices work is very, very important. You're not supposed to recap needles. You're supposed to dispose of needles and syringes in labeled containers, typically Sharps containers. OSHA, or the Occupational Safety and Health Administration, has developed guidelines for preventing needle sticks. They really want to try to push employers or companies to select safer needle devices because that will help to prevent and to decrease the amount of needle sticks that occur. Also, if there's a needle stick injury, it should be tracked using a Sharps injury log. This type of injury should be reported to HR. It may be considered a workman's compensation situation, and as a healthcare provider, you most likely are going to need follow-up and treatment for said needle stick injury. Okay, intradermal drugs. So, intradermal drugs are given in typically the most common site is this inner part of your forearm right here. Okay, and this is not one of the most commonly used routes, but however, we use it for allergy testing if you've ever had that done or have children or friends that have had that done. Local anesthetics, so like if I want to give a little lidoderm prior to inserting an IV, a peripheral IV, I may use intradermal, and also for TB testing. That's probably the biggest one that you guys have had intradermal done to you for. So when we talk about intradermal, it's just administered by injection between layers of the skin, okay? You're going to wear a glove, you're going to cleanse the site in circles, and then the needle is inserted at a 15-degree angle with the bevel up. When you correctly give an intradermal dose of medication, a little bump will form at the insertion site. That is exactly what you want to happen, a little tiny bump. You don't pull back or aspirate on the plunger. You don't massage the area. If a little bump does not form, the drug has probably been injected too deeply into the subcutaneous tissue, and the test results may or may not be accurate. You always want to make sure that you check your patient for any allergic or sensitivity reactions to the injection, and these reactions may take several hours to several days to become apparent. Okay, so this is actually an example of an intradermal injection. And if you see that little bump that's forming there, it's a little bit discolored from the rest of the skin, that's called a wheal. We call that a wheal. So you want to see that wheal develop as you administer that intradermal medication. And it's about a 15-degree angle as you see. Okay, subcutaneous medications. If a medication is given by sub-Q route, it's injected into tissues between the skin and the muscle. Common sites of subcutaneous drug administration are the upper arm, the abdomen, and the upper back. Subcutaneous drugs are absorbed more slowly than intramuscular drugs. Common drugs that we see administered via subcutaneous route are insulin and heparin. Those are two you will most likely as a nurse give a lot. Typical Dosages range from 0.5 to 1 milliliter, small amount, and we insert the needle at a 45 to 90 degree angle. How do you decide whether you go 45 or you go 90 degrees? Well, if your patient is large or obese, you may need a 90 degree angle to reach the subcutaneous tissue. If your patient is thin, you may need an angle that's 45 degrees or less. So it really depends on your patient's body habitus what degree angle you're going to use to correctly give them a subcutaneous medication. You always want to inject the drug and then remove the needle and apply pressure afterwards to prevent bleeding if needed. Make sure you document giving the medication immediately, including the site used for injection. So where did you give it? Why do you think that's important to document the site? Anyone have any ideas? Well, for one thing, it may help you to identify any adverse site reaction at a later time. Also, it will ensure that the person that comes after you to administer that medication will use a different site, therefore rotating sites, because that's really important with injections. We want to make sure that we're rotating sites for patient comfort. Okay, this is a subcutaneous injection. So you see that tan layer, that's actually the fatty tissue. Below that is the muscle tissue. Okay, so that's being injected at a 45 degree angle, so we can most likely assume that this patient is of normal size or a thin body size. Okay, intramuscular medications. A drug given by the intramuscular route is given by injection deep into a muscle. Because of the rich blood supply in the muscles, IM drugs are absorbed much faster than subcutaneous drugs. Now, injections should be about 1 to 3 milliliters. If you're going to have more than 3 milliliters, you're going to give that medication in 2 different injections. Typically, a good average is about 2 milliliters if you're going to go into a patient's arm. Excuse me, so common sites are the deltoid, the vastus lateralis, the ventrogluteal muscle of the hip. So you're going to help your patient into a comfortable position that is appropriate for the site. The dorsogluteal site, which is like if you take the butt cheek and you divide it into 4, that upper outer 4th section is the dorsogluteal. That site used to be very commonly used for IM injections. However, it's not a very favored site anymore because of the presence of a lot of nerves and major blood vessels there. So you have more potential to insert that needle straight into a blood vessel inadvertently. Okay, so here is that intramuscular injection. This is typically a 90 degree administration because we want to make sure we get deep into the belly of that muscle. So you're going through the epidermis or outer layer, the dermis, the subcutaneous, and the muscle to give that injection. Here is how you identify the deltoid site injection. So what you do is you go 2 finger widths below that bony prominence up here on the deltoid. So it's actually very high, okay? And then you kind of go right in the middle underneath those 2 fingers. Do you see that where that X is? X marks the spot. Lower than that, you are going to encounter blood vessels that are going to make it more difficult to safely administer a deltoid IM. Here is the ventrogluteal injection site. Again, this one is not always convenient. It's probably best to have the patient lay down, and it's typically not the quickest, but you can do this site. Then you have the vastus lateralis. This is actually a muscle that is up your thigh muscle, and this is a very appropriate place to give an IM injection. Okay, so when you're giving an IM medication, you're going to wash your hands and wear gloves. You're going to cleanse the injection site and insert the needle into the muscle at a 90 degree angle. If blood appears in the syringe, Immediately remove the needle and discard the drug. That means you've probably hit a blood vessel, whether it's an artery or a vein. If you need to, if there's bleeding, please apply pressure to that site, but you're going to need to get a new dose and a new needle and try another site. Now, some medications we give with the Z-Track method. And we're going to talk about the Z-Track method. So this is the Z-Track method. So you displace the tissue downward away from the injection site. So you kind of use your finger to pull the skin towards you or downwards. Then you're going to inject while holding the tissue away or downwards. And then you're going to allow the displaced tissue to move back into place. Why do you think we use the Z-Track method, which actually is becoming more and more popular method for all IM administration? Well, the thing is, by leaving that zigzag path, it prevents drug leakage into the subcutaneous tissue, helps seal the drug into the muscle, and it irritates or it minimizes skin irritation, and it also makes sure that absorption occurs properly since it's going into the muscle of the patient. So you are going to put the drug in a syringe. You are going to select and cleanse the site, pull the tissue laterally and hold it. You're going to insert the muscle or the needle into the muscle, inject the drug, and release the tissue as you remove the needle for proper IM administration. Okay, as far as giving intravenous drugs, these drugs are injected directly into the vein. Most drugs are given slowly through an IV. You can give medications IV push or IV piggyback. Before you give an IV medication, you always want to make sure that the IV site looks good and that the IV is patent. Patent means open or working. And you want to ensure that there's not a lot of air in the tubing. In theory, it really takes about 2 whole empty air-filled tubings to cause any problems for your patient. However, we don't ever want to test that theory, so try to remove all air from tubing if necessary when giving an IV medication. This route of administration is used when a drug needs to enter the bloodstream rapidly or when a large dose of medication needs to be given. If the drug is to be administered in a continuous IV infusion or an IV piggyback, so we give IV antibiotics as piggyback, it should be placed on an infusion pump to control the rate. In most cases, and this is such in the state of Missouri, although I hear it's being looked at, RNs or registered nurses will give the IV push and potentially IV piggyback drugs. Although as an LPN, it's still within the scope of your practice to understand this route of drug administration. Okay, so this now is an example of an intravenous injection. So you see they've highlighted the vein that's blue, right? And then you see that angle, it's going right into the vein, and then we're going to inject the medication right into the vein. So once you've given an intravenous drug, you want to document that it has been given. You also, for IV drugs, want to include the site and the rate of how fast the medication is infusing. You want to check the IV site for any sign of infection, extravasation, and infiltration. So infiltration is probably one of the most common adverse reactions or effects of an IV. Infiltration means that excuse me, that needle has somehow pierced through that vessel and there's fluid that's actually filling up in that tissue surrounding the vessel. So the site may look swollen, it may look red. You also want to monitor the patient for side effects, adverse effects, or expected effects of the drug. Remember, This medication is going to work pretty much instantly, right? Within just a couple minutes, because it's hitting the bloodstream, going straight to the heart, where it's going to be metabolized and excreted very quickly. So you're going to notice any side effects or adverse reactions very quickly with this route. Okay, now we want to talk about percutaneous drugs. These drugs are applied to and absorbed through the skin and mucous membrane. So what factors affect absorption of percutaneous drugs? Well, the size of the area, the concentration or strength of the drug, the time the drug remains in contact with the skin or mucous membranes, and the condition of the skin. Also with percutaneous drugs, I'm going to go back here. It's important to note that sometimes less is more. Oh, I can't go back. Sometimes less is more. So if they call for cream to be put on, you don't necessarily need a big thick layer of cream. Sometimes just a very thin layer of cream does the exact same thing, and there's really no reason to waste medication and do a thick layer. So look at how that medication is supposed to be administered percutaneously, how much they want you to put on the patient's skin. As far as topical or transdermal drugs, topicals are applied directly on the skin. They help to soften or lubricate the skin. Topical drugs include creams, lotions, and ointments. Transdermal route is applied to the skin, but it is absorbed and enters through the bloodstream. So it allows the patient to maintain a steady blood level of the drug. So common transdermal drugs are nicotine patches, scopolamine patch, fentanyl patch, lidoderm patch. These are just some examples. Nitroglycerin patch. So they're either applied as patches or ointments, and common sites of application include the chest, flank, back, and upper arms. You always want to make sure that you remove a patch prior to putting on another patch. Why do you want to make sure you do that? Well, because the patient could potentially be overdosed if they have too many patches on, right? So when you're applying a transdermal patch, you want to make sure that you remove the plastic backing very carefully, and you want to be especially careful not to touch the medication that will absorb into your skin. Here then, you want to make sure that when you apply the patch, you apply it nice and evenly on skin that is not irritated, broken, scabbed. There's no skin breakdown there. Okay, now giving topical or transdermal drugs continued. You want to wash your hands and put gloves on. You want to cleanse the area of the skin where the drug will be applied. Apply topical drugs in a smooth, thin layer and cover the entire area. Before you put on new topical drugs, you want to remove all traces of the drug from the previous dosage site and rotate sites. Again, we want to remove all traces of the drug previously to prevent any errors with dosage or any overdosing for the patient that could further cause adverse effects. When you put a transdermal drug or a patch drug on a patient, you want to make sure that you write the date, the time, and your initials on the new patch. Okay, giving drugs through the mucous membrane. You guys, we're on slide 51. We're in the home stretch. We only have 6 more to go, okay? So, drugs are well absorbed through the mucous membranes. However, blood supply to the mucous membranes does vary. So when you administer a medication through the mucous membranes, be sure to use a sterile procedure before placing eye drops or ointments, and clean procedure before giving drugs into the ears, nose, mouth, or vagina. So buccal or sublingual drugs are given in the mouth. Buccal or buccal is usually given like right inside the cheek, whereas sublingual is given underneath the tongue. Remember, I said that's a very vascular area. I said that on Friday. Drops and ointments are applied to the eyes, nose, and ears. Inhalation drugs are drawn into the lungs. And suppositories and creams are used in the vagina. Okay, important thing to know about a sublingual administration, the patient should not eat or drink until the drug is completely dissolved. Another common sublingual medication that's given is Zofran. Comes in a sublingual dissolvable form, and that's really nice for your patients who are experiencing nausea because it doesn't go all the way through the GI tract, obviously. It's absorbed and through the mucous membranes, and it can work very quickly for that patient to help with their nausea. You're going to wash your hands and wear gloves. You're going to follow the medication rights of administration. And like I said, drugs that are given in the mouth, especially sublingual, are dissolved very quickly. So there's a drug, a buccal or buccal drug given in the side of the cheek there. And then sublingual drug, you can't really tell, but that tongue is lifted up and that's given underneath the tongue. Okay, now giving ear and nose drops. So eardrops are drugs given to treat local infection or inflammation and should be kept at room temperature. Sometimes a cotton ball is ordered to be placed in the ear canal. Repeat this procedure for the other ear when both ears are affected. So for the ear, patients should lie on their side with the affected ear up. If they're younger, like a child, you should pull the lobe of their ear down and back. So I want you guys to try that. Down and back. If it's an older adult, like all of us are adults, we're going to pull the lobe up and out. That's going to help that eardrop have the most maximum effectiveness. Now, in theory, a patient should stay in that position on their side with the affected ear up for 5 minutes after that medication has been administered. With children, that's often a difficult task, but if parents get creative and nurses get creative, sometimes we can find distractions to keep them on their side for at least a little bit so that that medication works the best way that it can. As far as nose medications, you hold the dropper over the nose and give the ordered number. Nose drops or sprays are most often used to treat congestion or infection. I'm thinking of Flonase. That's the biggest one you'll see administered most likely, especially in St. Louis, Missouri with all these allergies. Okay, so this is just a picture of giving the eardrops. You see children younger than 3, you pull the earlobe down and back, and children older than 3 and adults, you pull the earlobe up and out, and that ensures that that medication gets into the ear canal correctly. Okay, so as far as this is the very last slide, guys, you're doing great. We're 1 hour and 3 minutes into this and almost done. So giving nasal sprays and inhalers and vaginal drugs. So nasal sprays are absorbed quickly from the nasal mucosa. You do not want to use the same spray container for another patient. You want to make sure that you position the patient sitting up with one nostril blocked by a finger, and you just place the tip of the spray in the other nostril as you block that other nostril. I always encourage my patients, if they can, to do these independently and by themselves. Obviously, I'm observing them to make sure they use the right technique, but I think sometimes it's easier for the patient to self-administer these if possible. If not, and you need to administer, the correct administration technique is on this slide. Drugs may be inhaled through the respiratory tract. So we're talking about like nebulizer treatments, albuterol and Atrovent, for example, can be inhaled through the respiratory tract or any kind of metered dose inhalers. Let's see, as far as vaginal medication, creams, jellies, tablets, and foams are given with a special applicator that is placed in the vagina. Vaginal drugs are given to treat infection or irritation. And you want to be sure to try to have the patient lie down for 10 to 15 minutes after receiving this medication so that absorption occurs properly. Thank you guys for watching this PowerPoint. I hope that this has helped you with the material in Chapter 2 of your pharmacology book. If you have any questions, please make sure that you reach out to me. I'm more than happy to answer any questions or help. And on Friday, we will plan to go into Chapter 3 and dosage calculations in class. Have a great day, guys.